Good day. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you to our Wednesday webinar series entitled Medical and Public Health Considerations of COVID-19. Today we are in store for a really fascinating and timely presentation on the racial and ethnic disparities and COVID-19, time for reflection, review, and reaction. Next slide. I'd like to thank our webinar series partners for getting out the word about this webinar series. Much appreciated. Next slide. All these webinars are recorded and are posted to the ACMT webinar page at acmt.net/COVID-19 web. You'll all receive an announcement approximately 48 hours after it's posted. We also developing a series of webinar Q&As that are found on our acmt.net/C19 FAQ page. And any questions about this series can be directed to us at info@acmt.net. Next slide. We will have a Q&A at the end of the webinar. We usually set aside 15 to 20 minutes for this. So please chat in your questions. You can type them in either into the Q&A box or the chat function, either on the WebEx platform or also on the YouTube or Facebook Live platform. Next slide. None of the speakers have any conflicts of interest to disclose. Next slide. I'd like to welcome my co-moderator, Dr. Ziad Kazi. He's a board member of the American College of Medical Toxicology and president of the Middle Eastern North African Clinical Toxicology Association, a faculty member at Emory University in Emergency Medicine and Medical Toxicology. Next slide. I'd also like to provide a warm welcome to our guest moderator today. Jillian Theobald is the Associate Medical Director of the Wisconsin Poison Center and an Associate Professor of the Department of Emergency Medicine at the Medical College of Wisconsin, and she'll be helping out with the Q&A toward the latter part of the webinar. At this point, I'd like to turn, next slide, turn the webinar over to Dr. Kazi, who will provide a introduction of the speakers today and also provide a little bit of background about his last 24 hours.
Thank you, Dr. Wax. I apologize if there's any problem with my connection. I'm currently in Beirut, Lebanon, and Dr. Wax has asked me to provide just a 2-minute update about the recent events in Beirut. Yesterday at 6 p.m., while I was in my apartment in Beirut, my parents and I were rocked by a horrific explosion. Actually, there were two near simultaneous explosions that really shook us and devastated us completely. The ensuing couple of hours were hours of panic and distress, where we were trying to figure out what was going on. Initially, we thought this was maybe a warfare type attack or warfare type situation or a terrorist attack. However, rapidly we heard on the news that this was an explosion at a firecracker storage area at the port of Beirut, which is in downtown Beirut, where I'm located. We saw some images or videos of the explosion and quickly realized that there was a blast wave, not what you would expect in a firecracker explosion, which is a low-order explosive and would not cause such a visual explosive, landscape. So at that point, they reported that this could be a ammonium nitrate explosion, ammonium nitrate that was stored for a incomprehensible reason at the port of Beirut for the last several years. I realized rapidly the importance of messaging and public messaging and social media, as I saw a number of false and misleading rhetorics online, whether this was a nerve agent attack, whether this was depleted uranium, a nuclear detonation, an attack by Israel on Lebanon, and vice versa, or a terrorist attack. So I really realized the importance of us healthcare providers providing the right message, an evidence-based message, which is similar to what we do in our webinar series. Early morning on Wednesday, which is today, I headed to the American University of Beirut Medical Center Emergency Department to relieve some of the providers that were working there last night. I was joined by colleagues of mine at ACMT, like Dr. Sheryl Heron, who's an emergency physician and toxicologist at Beirut. And I was shocked to see the number of victims in the emergency department. Some of them are still active. Others are still arriving because of delayed of rescue. And saw the whole gamut of blast injuries from globe ruptures to pneumothoraces, crush syndrome, head injury, extremity injury. And on top of that, I also was humbled by seeing our continuous pandemic with 2 patients with COVID-19 in the emergency department. And really made me think about how fragile our healthcare system is. Our emergency department had cared for about 400 victims of the blast, in addition to COVID-19 patients. And to me, this was really a moment of truth that we are living in a world that is fragile, and the healthcare system is one of the weakest links in in our reality. And the importance of prevention. Us as healthcare providers have a role and duty to prevent these disasters, whether they are of pandemic nature or an explosive incident like this. It also reminded me of the importance of fostering chemical safety and chemical security globally. These incidents can happen everywhere. They've happened in Texas. They happened in Beirut yesterday. And I really hope that this painful loss of lives will teach us something for the future. And again, my thoughts go to all the Lebanese who have lost family members or friends in the last 24 hours. And thank you for allowing me to provide this update. Turning back to our webinar, it is my honor and pleasure to introduce 2 champions of this topic in the US and around the world. Dr. Lisa Moreno is the president of the American Academy of Emergency Medicine. She is the professor of emergency medicine and the director of research and the director of diversity section in the Department of Emergency Medicine at Louisiana State University in New Orleans, Louisiana. She will be joined by Dr. Sheryl Heron. Dr. Sheryl Heron is a professor and vice chair of faculty equity, engagement, and empowerment in our Department of Emergency Medicine at Emory University. She's also the inaugural, newly appointed Associate Dean for Community Engagement, Equity, and Inclusion at Emory University School of Medicine. I promise you, you will be inspired by their passion, you will be impressed by their knowledge, and you will really follow their call to action by the end of this webinar. We will start with Dr. Lisa Moreno and follow with Dr. Heron. Lisa?
Thank you so much for having the 2 of us on this webinar. We really appreciate the opportunity to share about this critically important topic. And before I start, I do want to, on behalf of the American Academy of Emergency Medicine, express our condolences and support and ongoing prayers for Beirut. AAEM has a chapter, the Lebanese chapter of the American Academy of Emergency Medicine, and I work alongside Ziad Kazi many times at American University in Beirut. So we definitely feel personally affected and personally involved with what has gone on, and our prayers will continue for AUB, Beirut, and the country of Lebanon. So today we're going to talk about the data in COVID-19 in Black and Brown populations, as well as the impact of these findings. And then we're going to go over the impact on wellness and mental health and how we can respond to what's going on in the world today. So when we look at the demographics by race, and this is critically important because as a researcher, one of the things that I know and that I teach and that I've been taught is that in an ideal world, an ideal situation, an ideal universe, meaning that there are no variables at play and opportunity is equal for everyone. In that circumstance, the percentage of people who are represented in any cohort should equal the percentage of people in that universe. So when we say that the universe is the United States of America, which is 67% white, then we should say that represented in every cohort should be 67% white. So 67% of the people who get COVID should be white, 67% of the people who die from COVID should be white, 67% of the lawyers in the country should be white, 67% of the sanitation engineers, 60% of the prisoners in jail, et cetera, et cetera. That's the logic of it. And so when you look at New Orleans, we do have a significant difference. Our city is 59% Black and only 33% white, and we have 5% Hispanics and 3% Asians. So for us, it's a little different, but again, the same principles of research hold true if everything is equal in the United States of America. But let's look at the COVID statistics. So when you look at the population of the United States, those who have been tested, 16.56% of patients nationally, I'm sorry, there's a misplaced, it should be 1.656. There's a misplaced punctuation mark. The positives of the ones that were tested have been 30%, and the percentage of people who died who were positive is 5.6%. In New Orleans, our statistics are unfortunately worse. Even though we are doing more testing, we've tested almost twice as many people, but our positivity rate is lower than the nation as a whole, but our death rate is higher. And so those of you who had the opportunity to see the president talking to a biologist, epidemiologist yesterday, we do know that this can be a little bit confusing. We're doing more testing, so of course we have more positives because we're doing more testing. But the death rate should not have anything to do with how much testing you're doing or how much testing you're not doing. And so our death rate is higher than the death rate in the United States. And to set the facts correct, the death rate in the United States is one of the highest in the world. Depending on the study you're looking at, it's either the third highest or the fourth highest in the entire world. When you look at Black population versus the Black COVID death rate, however, and remember I told you that all of the rates should be equal, when you look at places where there is a higher Black population, like in New Orleans, Chicago, Milwaukee, as examples, you look at the Black death rate compared to the Black population, and you see, shockingly, that the death rate in all cases is more than 2 times the rate of African Americans in the population. So you're seeing a rate that is 2 times. So something is clearly wrong, because I told you that if all facts are equal and everyone has equal protection and equal opportunity, then the death rate should be equivalent to the population rate. So the dark blue bar and the light blue bar should be right even with each other, and yet they are not. The death rate for Blacks is 2 times, more than 2 times, the rate of Blacks in the population. And so when you look at comorbidities, so frequently comorbidities are attributed as a reason that the death rate is higher. So you're looking at the maroon bar, which is COVID deaths that are associated with each of these comorbidities. So the percentage of people who have cancer and die of COVID, who are obese and die of COVID, who have diabetes and die of COVID, hypertension and die of COVID. And then you look at the light blue bar, and that light blue bar tells you the number of African Americans or Black people who have that condition of comorbidity. And the dark blue bar shows the number of white people or percentage of white people who have that comorbidity. And so you see very clearly that Blacks have a higher rate of hypertension, diabetes, and obesity, and pretty much the same rate of cancer as whites, but a higher rate of hypertension, diabetes, and obesity than white individuals do. Again, what we expect is that the percentage of Blacks suffering from these conditions should be equal to the percentage of Blacks in the population, but that is not what we see. We see that whites are actually underrepresented in the comorbidities, with the exception of obesity, and that Blacks are overrepresented. And we have to ask why. We have to ask, why are people of color overrepresented in these comorbidities? And those things go back to the history of our country, where we say that clearly there are not equal opportunities for all people and there are not equal protections for all people. Poverty is a strong correlate for disease, and the living conditions of people who are living in poverty definitely are added risk factors for COVID and other infectious diseases. So when you look at the percentage of people in the United States in each demographic, and then you look at New York City, which the president said should actually be taken out of the statistics for looking at the United States because of the fact that New York skewed things with COVID. But New York is part of the United States, and so is Louisiana, and so is New Orleans. And so we do need to look at these statistics as part of the United States. But you see that more people are living below the poverty level in the parts of the country that were vastly impacted by COVID-19. So even more whites are living below the poverty level, but clearly more blacks are living below the poverty level, and more Hispanics are living below the poverty level. And Hispanics living below the poverty level in New York City, that percentage is vastly higher than in the United States as a whole. And we do know that Hispanics in New York City, or Latinx population, was the one that was most affected and overrepresented in COVID. Income disparities by race and gender also impact children. So 40% of U.S. households are headed by women, and the status of these women is then going to impact their children. And we know that that poverty, as I said, is a risk factor for infectious disease. It increases the likelihood that a person will contract an infectious disease. And when we look at U.S.-born women, we see that Dominican female head of households are the most likely to live in poverty. Hence, their children are living in poverty. And of women born abroad, and the United States, for some reason, although they own Puerto Rico and have colonized our country since 1898, but they still say that if you were born in Puerto Rico, you were born abroad. And of women born abroad, Puerto Rican female head of households are the most likely to live in poverty. Nutritional disparities. We also know that nutrition is a factor in not only how one's immune system functions and one's ability to tolerate the overall stress of disease. 35.3% of female-headed households are food insecure. And when you look at the nutritional disparities in the U.S., only 2.2% of U.S. households live in food deserts, but in the areas that are predominantly the residences of people of color, 16% of the Bronx is living in a food desert, and those populations are predominantly Latinx, and 13% of Manhattan households, where the population is predominantly Black and then Latinx, are also living in food deserts. And up to 87% of New Orleans' 175 census tracts meet the USDA's definition of a food desert. So this is no supermarket in 1 mile, meaning that you really cannot walk to a supermarket and carry your groceries home comfortably. And obviously, we know most people don't have access to car ownership. Multi-generational households have also been cited by the experts, by the President's panel, and by the CDC as having an impact on the spread of COVID infection and the likelihood that COVID infection will be contracted by a householder is related to how many people and how many generations are living in their household. So if you look at the statistics, you will see that most of the intergenerational households in the United States are located in the South, Hawaii, New York, and New Jersey. And all of these have high concentrations of COVID and have high concentrations of Black and Brown citizens. Only 3.7% of white people live in a multi-generational household. Pacific Islanders have the highest at 13%, followed by Native Americans and Latinx populations at 10%, and Blacks at 9.5%, almost the same, Asians at 9%, and multiracials at 8%. So this is another risk factor for contracting COVID-19. When you look at educational disparities, and we also know that education is protective of health comorbidities. There hasn't been a study to link it to COVID specifically, but there have been hundreds, if not thousands, of studies that have linked education to the comorbidities that increase the risk of death from COVID, such as obesity, hypertension, and diabetes. And when you look again at the United States, you see that there is a clear disparity in education rates between Blacks, Hispanics, and whites. And when you look at the cities that were most impacted, New Orleans, where I live, New York City, where I'm from, you see that the disparities are even more and more pronounced. In New York City, whites are actually overeducated as compared to the general population. And you see that other individuals are significantly, people of color, Black and brown people, are significantly underrepresented in the area of bachelor's or higher, and overrepresented in the areas of high school or GED and did not graduate. There are also information disparities. Information access is critical to receiving news and understanding what's going on in your city, what the risk is in your city, and what the recommendations of your governor and your mayor are for protection against COVID-19. Homes that lack internet access in the United States are only 6%, but in New York City, 27% of city dwellers lack internet access, and 17% of New Yorkers don't even own a computer. And in the city where I'm currently living, it's even more profound. 33% of New Orleans homes do not have internet access, and 21% of New Orleans homes do not have a computer. So this creates a situation where people receive information from television, and as we know, that it's not properly vetted by experts and can result in misinformation and inappropriate or even dangerous behaviors, such as instructions to drink Lysol or do similar things that, if you don't have access to the internet, you can't always get accurate information and opinions that correct the things that the television is telling us inappropriately. So overall, disparities are prevalent through the United States, and particularly in large and high minority urban centers. COVID disparities were expected by Dr. Heron and myself, and all of us who work in diversity, equity, and inclusion. We knew that COVID would be overrepresented among our people and populations of colors, because these disparities mirror the disparities that disadvantage communities and individuals of color in all illnesses and injuries, except suicide and drug addiction, in which whites prevail. We know that disease disparities have their roots in the historic prejudices and injustices that characterize the treatment of people of color throughout history, and they will not be ameliorated or remedied without concentrated efforts to mitigate their causes. So at this point, I'm going to turn it over to Dr. Heron, who is going to do some reflection, review, and reaction to the statistics that we've presented about COVID-19. Dr. Heron?
Well, thank you, Dr. Moreno, and to all 517 of you on this webinar. We don't take it lightly that you have taken time out of your busy schedules to participate in this webinar. As you have heard, is near and dear to both mine and Lisa's hearts. I'd also like to take the opportunity to thank Dr. Wax, Dr. Kazi, my friend and colleague here at Emory, as well as our moderator, who, Dr. Theobald, who will take us through the end of this conversation. And this particular section on reflection, review, and reaction should give us pause. And while we pause to think about Beirut and our colleagues there who have gone through some very challenging times and painful times, as we consider COVID-19, I ask you to reflect, review, and perhaps offer your reactions of what you have just heard related to the statistics by Dr. Moreno, Dr. Lisa Moreno, my friend. So this slide is a potpourri of several of the reflections and perhaps reactions that you may be aware of or maybe not aware of. Dr. Moreno talked about, some of the things related to the mental health and challenges that are unique to communities of color, who are in this pandemic. And she ended her discussion by talking about the historical cause, as you see up in the left-hand corner of your screen, that contributes to the mental health challenges for communities of color, for Black and Brown people. We cannot deny the legacy of racism, homophobia, transphobia, ableism, economic stressors, and systemic failures that contribute to the mental health struggles for all people, but notably for African Americans. And we can't deny that COVID-19, as you have heard in the data, not only have amplified the underlying challenges of diabetes that contribute to death, hypertension, and obesity, but I would offer also contributes to the amplification of distress that the article up on the left speaks to. What it does bring the question to mind is, the Brookings Institute did a study looking at the well-being and mental health amid COVID-19 differences in resilience across minorities and whites. And for those who are not familiar with the Brookings Institute, it was founded in 1916. It is what we call the think tank out of Washington, D.C. They do research on social sciences, economics, and they route themselves to look at, large data sets to examine what the findings might be related to multiple areas that impact our society. And this paper published, this policy paper published in June by Dr. Graham and her colleagues, looked at, what and how do people of color, mental health-wise, how do they respond? Are they resilient? And one would argue that they shouldn't be. One should argue with, given the data that you've just heard, that Black and Brown people should, ironically, perhaps be worse, but they are not. The findings that were puzzling to these researchers suggested that low-income African-American groups, while they had the disproportionate burden from COVID-19, were actually much more resilient than specifically low-income white populations. And why they found these differences to be so, and while they want to delve more deeply into this, they argue that the resilience is complex. And the complexity is really routed in the historical trajectory of how Black and Brown people have overcome adversity over the decades and centuries living in this country. African Americans, Black and Brown people have strong community ties. They have a strong belief. They have a strong faith. They have unfortunately become accustomed to their low income realities, which have become extremely prominent now, as you've heard of low income whites now marching onto the scene. And so this reality has enabled, paradoxically, to strengthen the resilience of Black and Brown people. And we find that to be an area that deserves further examination through this COVID-19 crisis, to really think about how these realities of having unemployment historically and having poor access historically has paradoxically given the resilience that this Brookings paper brought to light as we look at COVID-19. And we find that while Black and Brown people have lost their jobs, they tend to be more optimistic and report better mental health than whites who have lost their jobs, because that is unfamiliar territory. And they are just truly trying to figure out and face these realities with increased consumption of alcohol. We see increased incidents of suicide in white populations. And these are the paradoxical realities of what we have seen related to the well-being and mental health amid COVID-19 differences for minorities and white. And then, of course, there's the caring for mental health in communities of color, because while we are resilient, perhaps, and I am a Black woman living in America, and this is personal to me, having worked personally and gone to my own church, There's a clear lack of access to testing that Black and Brown people have encountered. This piece written in May speaks to that. The fear of being profiled while wearing a face mask as a Black person because of the increased risk of perhaps profiling by police and or arrest by police. The stress and the strain in communities of color, having seen the outcome of what has happened with George Floyd and that death, which then brought people together, then of course putting them more at risk. The paradox of whether one should be fighting for justice in the midst of trying to stay safe. Next slide, please. And I, for one, next slide, please. I, for one, felt that very same pain and suffering. And one of the things that I opted to do was write. And, this piece that was published by the Harvard Macy Institute in July of this year really had me reflect, which is one of the pieces of what we asked you to do, to review and to reflect and think about how COVID-19 perhaps affects you and Black and Brown people who are around you. And in this particular piece, I have to say it hit home for me from the standpoint of resiliency and the need to share my thoughts. I work in an inner city emergency department that cares for predominantly African American people of low socioeconomic status. And as a Black woman caring for the increasing number of these patients that were coming to my emergency department, this reflection compelled me to write about what I had seen and, more importantly, what I had felt. And the 3 things in 5 communities was born out of the belief that I have and my fundamental lens towards caring for communities and communities that look like me, who are African American. And the 3 things really specifically in the midst of this pandemic are something to do that is meaningful, someone to love who can shepherd you through these very challenging times, and something to look forward to. In the essence, we call that hope. And without hope, I dare say that notwithstanding how long we will be in this COVID-19 pandemic, we must find and we must seek the resilience necessary through the hope that will be provided. The 5 communities, however, to assist us along the way and along this life journey, even more relevant during COVID-19, are your communities of origin. The communities of origin such as your parents or your grandparents. I am not ashamed to say that I have my parents living, but they are in an assisted living. And the pain and suffering that African Americans have, and I would dare say all people have, in not being able to see their loved one is real. And that community of elders who are at higher risk, we know that data tells us that contributes to some of the pain and the suffering, particularly in African American communities that tend to be communal. Communities of creation, who do you partner with? That would be your second community. Who do you have children with? Dr. Moreno spoke of women who are 40% of the households. And if that community of creation and that community of partnership is that much more decimated by COVID-19, it's certainly more exacerbated during that time. The third community would be your community of work. We see that people have lost their jobs. We see that we are seeing increased unemployment. And you see and know that with this, there is increased stress and therefore a need for resilience. Your fourth community, community of neighbors. If we are looking at more people who are undomiciled and don't have access to their neighbors, how could they then be a part of one's resilience and tank to fill you up, particularly during this crisis? And of course, we know there's a community of faith for those who believe. I'm a Christian woman. I have my faith at my church. I was able to go into my church and provide services such as COVID-19 testing, even in the space of trying to manage that in my own emergency department. Next slide. But that doesn't tell the whole story, because the rest of the story has to be routed in how do we care for ourselves? And how do we care for ourselves, next slide, was really something that I took to heart as chairing the Wellness and Wellbeing Committee at Emory. And again, in the reflection piece that you see here that was published in the Journal of Wellness, it really spoke to me as someone, not only as someone of color, but really someone in the healthcare profession that knew that we were all at risk in our mental health, in our physical health, and our overall well-being in the midst of a pandemic. And what we needed to do as an institution, which of course includes our learners, our staff, and our faculty, is really think about how we could respond and how we could relate to move us all forward in this pandemic. And we took this really from Dr. Shannonfeld's work that he published early on in JAMA, where he is, of course, well known for his work on wellness and well-being. And he published a paper looking at the sources of anxiety among healthcare professionals during this COVID-19. And he summed it up really in 5 areas. Number 1, hear me. Are we listening to what our healthcare professionals are saying, especially those who are on the front line, those of us who are in emergency medicine? Are we listening to the fact that we need all of what we need for our PPE? Are our voices being heard, not necessarily just being cheered on when we are leaving our shift, but are we heard, knowing that we are putting ourselves at risk? Number 2, protect me, which goes again, access to PPE. We go home to our families, and the biggest fear is going home and infecting our families who are part of our community, part of those individuals that keep us whole and keep us well. So do we have access? Are we being protected? Those answers need to be given. Prepare me. Are we being prepared by the training that is necessary to go into unprecedented waters of COVID-19? And if you have learners, and if you have faculty, and if you have staff, all of whom are being isolated, and there's been lots of discussion about feeling guilty, how are we doing this, and how are we, with deliberateness, providing that space? And certainly, last but not least, supporting me. And this is really about the reflections piece. Are we giving our colleagues, are we giving our faculty of color in particular room to breathe while managing a pandemic and managing the protests that we have seen? Are we being supported in knowing the pain and the suffering that people of color, Black and Brown, are dealing with without access to daycare, without access to schools, without access to the physical means to get to, as you heard, groceries and the things related to that? So we took bold steps at Emory to pull ourselves together to think about these constructs and put together resources. Admittedly, this would be very cocooned if you are Black and Brown and don't have access, as we have heard, to computers where we can do virtual yoga, or you can have access to meals delivered to your home. This can certainly be problematic. So when you think about how to review and reflect and ask yourselves how we are impacting and responding to COVID-19, it has to be both from the lens of the disparities of care that you see for your patients, the realities of care for your colleagues who are Black and Brown, who are going through the mental anguish of caring for our patients, but knowing that there is the resilience that is underlying some of this to move us forward into a pandemic that we see no end at this time. Next slide. And with that, we leave you with this conclusion. We know that the data is real about Black and Brown populations. The disparities are clear. Dr. Moreno brought that very eloquently to this discussion. We know that it impacts the work that we need to do. We know that these findings tells us that we need even more data to look at the sequelae of COVID-19 in terms of the long-term effects on communities of color, the impact of not having access to seeing one's families or being around one's families in the communities that we serve, and the strategies of hearing us, seeing us, protecting us, to be able to react, respond, and give life to the systems, that are, as we call, the social determinants of health, but they're quite frankly, anti or racism, systemic racism that impacts people of color, and social justice that we must all live for and think about, particularly in this pandemic that we see no end at this moment as we move into yet another season of flu and colds, and we must be prepared. So I thank you for the opportunity to share these reflections and these thoughts, and I will turn it over to our moderator.
Thank you guys so much. What very interesting data you presented. There have been a couple questions that have come up, and I wanted to start with one of sort of the overall ones that addresses one of the conclusions that was made. Do you guys have any ideas or thoughts or strategies for how we can best address some of these disparities? Are there any sort of quick interventions that could be made in some of these communities that can help address some of these issues?
So I can tell you one quick intervention that can be made, and that is regarding testing, which we know is in a short supply. But many states and cities are requiring that individuals present identification and proof that they actually are a resident of that state or even that city in order to be tested at that testing site. This has decreased the testing among the Latinx population because many of us come from other countries and many of us are here illegally and are undocumented. And so there has been a tremendous fear among Latinx people to get tested. And clearly, if you do not know that you're positive, you cannot protect other people. The literature that was done about a decade ago in the HIV population showed that there is a 63% risk reduction, 63% behavioral risk reduction as soon as a person finds out that they're positive. And so this can easily be extrapolated into COVID. So if we're not testing people, if we're not allowing them to be tested because they are afraid that they're going to be arrested or deported if they get tested, then we're not facilitating this risk reduction behavior that they might exhibit if they knew they were positive. So getting rid of that requirement is a good public health measure that can be done immediately that will decrease some disparities.
Yeah, and I'll follow with that. Thank you, Lisa. The National Medical Association, which is the organization that has been the premier voice for Black patients, consisting of several thousand Black physicians, just ended and had an incredibly rich discussion by the Surgeon Generals, Black Surgeon Generals historically, as well as other leaders, to talk about this very question. What can we do? What should we do in the face of mistrust, distrust that has been historically a part of the narrative of the United States? Think Tuskegee and other experimentation on Black people that resulted in poor outcomes or lack of treatment. And one thing that was clear is we can, continue to message behavior that is protected. Wearing a mask, washing your hands, and using words, that would otherwise engender a sense of community. So not so much social distancing, which is, becoming less and less out of favor, and encourage words like geographical distancing. Because one of the things that's certainly come out of COVID is a sense of isolation. And people, it's not inherent to human beings to be isolated. And when you say, socially distance yourself, you are putting into the world that you should not be social, which is antithetical to human beings. So things that we can do is use language that will encourage and empower people. Either wash your hands, put on a mask. You can geographically distance yourself. And to Lisa's point, getting testing is one thing, but trying to demonstrate that behavior by engendering trust as to why this is happening. We are in a very peculiar time because there are so many mixed messages as we keep hearing, but in your own sphere of influence, one has to take ownership of that and lead by example. and offer our patients and so patients in particular, you know, the reasons and the rationale, notwithstanding the challenges of why this is important, so that the data shows us that we're having multiple patients coming up positive, but they can feel a part of the solution in helping us end this. On the other side of the coin, going to our colleagues who are stressed out and who are having, you know, difficulties taking care of multiple patients who are sick and perhaps bringing it home to your families, simple things like just stepping away, asking how people are doing, making sure that they are kept whole, acknowledging the toll that this is taking on people, recognizing the guilt that people may have throughout this pandemic. These are all things as we gather more data to do what we need to do to respond to our patients, i.e. having patient-centered care, which we know is extremely important, are some of the things we must commit to doing if we're going to really, as a community, not just address COVID-19, which ripped the bandage off of disparities of care, but all of the other concerns related to disparities of care for Black and Brown people. Thank you.
To follow the questions about testing, have you guys seen any evidence of increased COVID cases related to a lot of the racial protests that are going on across the country?
So there is no evidence that these protests have increased the rate, the case rate, or the prevalence of COVID-19. And in fact, if you watch the videos from the protests, you will see that the individuals involved in the protests have been very careful to maintain not social, because certainly there's no social distancing. People are coming together to speak and empower. But there is physical distancing and people are wearing masks. So there is a lot of consciousness about this. And this is in striking contrast to the things that we are seeing happening at political rallies where our leaders are coming together. We see COVID being spread there, but we don't see COVID being spread. There's no evidence that COVID is being spread during the political protests or the protests against the injustices that are being perpetrated.
I would just add that there's no evidence, but there is concern. Surgeon General Adams, who was just on the NMA 125 call with the Surgeon Generals, did make the comment, as did Georges Benjamin, the former president of APHA and executive director, that really does need to be studied. But there are some instances where people aren't masked. They try to be, but how do you make that correlation? It is just the proximity, because they are not marching 6 feet apart. They are marching quite closely together. So I would put a cautionary footnote that it's hard to really discern from what instance that people are gathering where this is coming from. But we do see multiple people in pools. We look at what has happened in Florida or other beaches where people congregate, and then we see, you know, surge cases and spiked cases. So it is truly the proximity that one has to have with one another, and there's no way to contact trace under those sort of situations where if one or two people may be exposed, even within that, there's no way to then really figure out who they may have been exposed to. As it relates to my position in the School of Medicine, I see that in the chat. As the Associate Dean for Community Engagement, you know, my role is to really look at the community, both internal to Emory and external to Emory. As such, one of the board members at Emory Healthcare, who's an African-American male, asked Emory straight, what are you doing to impact COVID-19 in communities of color? He's an African-American male under John Lewin. The Emory Healthcare pulled together a team of over 40 people to look at this in different domains, including collecting data, writing grants, working with communities to spread the message. I was at the Latino American Association rally, back to school rally, to talk about COVID-19 while we were distributing food supplies. So to be palpably and visibly present with masks and with appropriate, culturally appropriate materials to be distributed in Spanish so that people understand what we're trying to say, as well as the communications, putting together videos. And I'm working with on that committee as well to look at that in a clear, careful way based on what the community says would be most impactful and most effective. So in this new role that I have assumed, it's around equity and inclusion. So COVID-19 is a piece of it, but it's a larger lens to look at equity and inclusion writ large, which includes recruitment, retention of Black and Brown people, the climate that we're in, the historical lens from which we come. I would be remiss if I did not recognize, Honorable John Lewis and C.T. Vivian and Joseph Lowery, three incredible giants from the civil rights movement who were in Atlanta, and being honest about all of the impact that the community brings in my position to COVID-19 and other disparate care or health inequity, we should say, that is in our community. Thank you.
Speaking of disparate care and things in the communities, Dr. Wax brought up an interesting question, and this is somewhat near and dear to my heart with some of the issues we've had with voting here in Milwaukee, and cases traced to people standing in line for hours at the polls. Do you guys have any suggestions or possible ways to intervene to get communities of color out to the polling places, especially if they don't necessarily have access to the mail-in ballot? And with the new information or disinformation coming out about the validity of mail-in ballots. And so how do we get people there safely, especially in areas where a lot of the polling places are being shut down?
So this is a question. I'm in the state of Georgia with Stacey Abrams, who spent her platform trying to address voter suppression. And with embarrassment, we looked and saw how people were standing in line for hours trying to get to the polls. And there has been an incredible amount of energy, at least in the state of Georgia, to really try to push from, a legislative standpoint and inform the community, what their rights are and what they must do to be able to vote and to get to the polls. There is something that just came across my desk called Vote Healthy 20, which somebody asked me, are hospitals in a position to, set up and create an opportunity for, if you will, a captured group, admittedly maybe a small group, but we do have people still coming to the hospital while they can't get visitors per se because of COVID-19. They can the walk-ins, a couple of years back at our last election, we did set up something where people could have access. In this case, clearly it would have to be with the appropriate geographical distancing and availability of masks and hand washing to be able to do that. Interestingly enough, the testing piece, the study from Brookings also noted that people were less likely to have anxiety if they were COVID-19 positive, right? Which is an interesting finding, although I could see where people said, oh, I'm positive. Then the second question is, can I be positive again? And what does that mean? But we know, with immunology, how viruses work, that we feel somewhat protected. So the short answer around the protection and getting folks to the polls is to continue to do, door-to-door community engagement and be visible in terms of how people can protect themselves. To Lisa's point, if people are out there marching and protesting, right, they can certainly, go out there and vote, and we can certainly, as a country, demand that this be done in the appropriate manner that's safe for all people.
So I actually have a question myself. So as a mom of 4 kids under the age of 9, school has been on the forefront of my mind. And I was really interested to see Dr. Moreno's slide about how dramatic the educational disparities are across the U.S. And I have a lot of significant concerns about how these are just going to be expanded and even further made worse by a lot of the lack of access to internet and home learning, and then parents who work full-time trying to, homeschool their children without internet access. And so have you guys heard of, or do you guys have any strategies to help mitigate some of this risk, or some thoughts on how do we keep some of these, children of color in lower socioeconomic areas from being left behind? Because we don't really know how long the pandemic's going to happen and how long schools are going to be shut down.
So there's a lot of concern about this for exactly the reasons that you elucidated. Most of the parents who are working and cannot afford to have a quote-unquote nanny or some child care person in their home supervising their children's virtual education, and as you also spoke to, whether or not people even have internet service or have a computer in their home, and this is a tremendous concern. I think that some places, New York City at the present time, Mayor de Blasio is saying that he wants to open the schools, but the UTA, the United Teachers Association, is saying that this is unsafe, and that's especially important when we heard Dr. Ashley Compton, who is the state physician for the equivalent of the Surgeon General for the state of Arizona, said that it's completely impossible to guarantee a safe environment in the school. She raised some issues as like how many teachers are positive, how many students are positive, how would you test everybody, what would be the schedule for testing everybody, and who would be responsible to check that everybody's getting their tests and reporting their results to the school. So it's looking more and more impossible that schools can safely be opened, or that hybrid programs can even safely exist. And so the UTA in New York is actually beginning to plan with their teachers how to do really effective virtual education that may take up 5-6 hours a day, so that it can be more equivalent to what the classroom situation is, using platforms like we're using today, so that students have a chance to interact with each other. But then the other issue is internet access. And so again, that then behooves organizations, which the UTA is looking into, getting computers as part of a city or state assistance program into the homes of all children. Now, that's not going to solve the problem of who's going to take care of these children and supervise their education when moms are having to go to work and dads are having to go to work. And certainly among the Black and brown population, we are the ones who are least likely to be able to afford a nanny or an in-home child care person. So that is going to continue to be a significant problem, and I'm not sure how that is going to be addressed, but definitely teachers are being trained to do longer and more effective virtual education on tried and true tested platforms like this one and Zoom, and there is an effort that states should be providing computers the same way that the medical school provides a computer to every kid as part of their tuition.
Earlier, you had said that there was about 20% of people who don't have access to the internet and primarily get their information from TV. Do you have a good sense, or has anybody actually looked at this, is how disparate is the information coming from TV versus the internet? And do people commonly have differing perceptions of what's going on with the pandemic and how they're affecting different communities if they get their information from one source versus the other, or both?
I'm not aware of any studies that have been done, and I don't know if Sheryl has access to that information, but I'm not aware of any studies that have been done. I do certainly know anecdotally that patients are following some of the advice that they get on the TV and then coming into the emergency department sick or with complications because they followed that advice. And as president of AAEM, I have plenty of members who are telling me that, yes, they did have patients come in who swallowed Lysol, who drank Lysol, or who washed themselves with Clorox because they were told by the president that this was a way that they could prevent COVID. Even on this webinar, we had someone from Iran talking about the fact that people had been told that drinking alcohol could prevent you from getting COVID, and so they ended up ingesting homemade alcohol that had high methanol content, and people died. So we do know that this happens throughout the world. I don't know that there have been any studies on it.
I think we're just way too early, and I think there's going to be sequelae of all of this as I was listening, and I realize we're at the hour. But it does beg the question for philanthropic engagement in this space. It is an opportunity for big corporations to step up and step in, and I would imagine, we're trying at Emory and other places to really get funding, and people should be thinking about that on a larger lens to see how we can sort of, equalize where we're trying to go, because there is going to be an inequity, in terms of how people can perform, right? People go to their, I have people say, oh, I'm going to go to my family's home, and they take pictures and they're at the beach, right? They can go leave one home and go to the next because of their economic strength, where others don't have that opportunity, right? People may have to work 1, 2, even more jobs just to keep afloat if they're available, and jobs that are not protected in terms of their, true access to safety. So I think the data that's going to be collected over time will give us a second wave of understanding of what COVID-19 will do and has done in its devastation of communities. Thank you.
Sheryl, I know that you might have to leave. I just wanted to thank you so much for participating and providing your expertise on this really important topic.
Oh, it's my pleasure, and it's a conversation that must continue. I say this, time and time again. I've been doing work on this area in terms of disparity, diversity, equity for 24 years now, and we know that racism and slavery is over 400 plus years. So, if everyone is aware, and awoke, as we say, we can continue to chip away to get to the equitable place that we all deserve. Thank you.
Yeah. All right, so we'll probably just maybe do a couple more questions. So one of the questions that I think is really interesting that was posted was, given the stay-at-home order, has anybody been looking at increased exposure to some of these environmental toxins in unhealthy homes like mold, pests, and lead? And is there anything that you guys have heard about any ways that we can help mitigate some of these exposures and things we can do to help reduce the risk to others?
Well, in New Orleans, there certainly has been a chronic problem with mold since Hurricane Katrina. And we also know from multiple studies that have been done by our public health department and our water department that, people laugh and say that that we are the most Northern Caribbean country, and certainly we have the same problems that a lot of the Caribbean countries have. We are on boil water alerts frequently, where we are told that that we have to boil our water because it's not safe to drink. And again, a lot of times this information is being given to you by a text or being given to you by an email, which not everyone has access to. So while there are no particular studies that have been done focusing on the increased exposure to mold or the increased exposure to impure water, we do know that those people who tend to spend more time at home to begin with are people who are disabled, people who are elderly, people who are extremely young. And we know that in communities of color, which in New Orleans is predominantly the Black community, that families cannot afford to put their kids in summer camps, families cannot afford to put their kids in after-school programs, and so those children do spend more time in the home, and the parents who are more likely to be unemployed are spending more time in the home. With COVID, what's actually happening in our communities of color is that people are spending less time in the home, adult people. And the reason for that is that African Americans and the Latinx population are more often employed in the service industries that are considered essential. And so these individuals are working in supermarkets, they're collecting garbage, they're delivering mail, they are delivering packages. And these kind of jobs, although I'm sure that many of our essential workers would love to be lawyers working from home, but historically those educational opportunities have not been provided, and those economic opportunities have not been provided to populations of color. And so we have a much higher rate of populations of color that are actually outside the house all day providing essential services.
So I'd like to end with a kind of a really twofold question. So, and it's from two different participants molded into one larger question. So how have you as president of AAEM addressed some of these healthcare disparities? And then what can we do as healthcare providers and practice our political power as advocates and to establish or promote policy changes to address some of these health inequity and social determinants of health?
So we have a tremendous amount of power as physicians, despite the fact that a lot of things have changed for us in terms of being physicians in society in America. We still are respected. In fact, a survey that was done regarding COVID information showed that the general population has the highest level of respect for information coming from a doctor and are more likely to listen to a doctor than to a government official or anyone else. And that's good because we're the ones out there giving the accurate information. So we have a tremendous amount of power and we need to leverage that. So AAEM has been extremely active in issuing policy statements about face coverings, social distancing, and other public health guidelines, hand washing. We have been active in putting out videos and announcements and public health announcements, tweeting things on Facebook, etc. We are also supporting voter registration in the emergency department in these times, and we do have a couple of our members who are actually doing that. We are also supporting our physicians, and this is a really critically important thing. Physicians who are on the front lines, who are actually taking care of patients during the payouts that are taking place. A lot of the corporate medical groups have been saying and lobbying Congress that the payments should go to them because they are the ones who are employing the physicians, managing the physicians, scheduling the physicians for work. And AAEM has consistently been for physician-controlled healthcare and physician decision-making and against corporate medical groups who make a profit off of the illness and suffering of people and the hard work of physicians. And so we are trying to prevent abuse of physicians as well and to protect physicians' position, allowing physicians to make the necessary decisions based on the needs of their patients and saying that any of these payouts should go to the doctors and the nurses and the respiratory therapists and not to the corporations that are employing them. The other disparity that we are keenly aware of, which didn't come out in this seminar but is probably well known, is the fact that there are a decreased number of Black and brown people attending medical school. as I started with my first slide, the proportion of Black and brown people in the population should equal the proportion in medical school. And we know that the deficit of Latinx people in medical school is 70%, the deficit of Black males is 60%, the deficit of Black females is 40%, and all of the white and Asian groups are overrepresented. AAEM is partnering with SAAEM, and we are making, that's the Society for Academic Emergency Medicine, and we are making significant outreach to historically Black college and university medical schools, none of whom have emergency medicine residencies, and we are reaching out to them to mentor them during this COVID pandemic, during which time they are not permitted to do away rotations that would help them to get into residencies of their choice. So we are trying to ameliorate the disparity in access to medical education and access to residency training for physicians of color. So we're hitting it on all levels. We're protecting attending physicians, we're protecting medical students and residents, and we are protecting our citizens as best as we can. And certainly we plan to continue to do that and to do a whole lot more.
Sounds like AAEM is doing a lot in a lot of different sectors to help address some of these issues. I really want to thank you so much for staying on to talk with us and to provide your expertise. If you have any final remarks, I'd love for you to give them now. If you don't, that's totally okay as well.
So my final remarks would just be to highlight the fact that the disparities that we're seeing in COVID-19 are not a shock to those of us who have been doing this kind of work for a long time. Dr. Heron mentioned that she's been doing it for 24 years. I've been doing it for about 17 years. We expected this to happen because the disparities are deeply rooted in the history of slavery and the history of oppression of Caribbean islanders and indigenous people in the United States. We know that this is not going to go away overnight, but we have to take the first step, and we have to keep stepping and moving forward and doing the next thing that needs to be done. I think that this webinar and others like it are raising consciousness among healthcare professionals and among the general public. We need to be sensitive to protecting physicians of color, to insisting that physicians must control the narrative when it comes to healthcare, and to increasing the number of Black and brown individuals in medical school and in residency programs, and to being sensitive to the fact that our most vulnerable populations are the ones without internet. They are the ones with the highest risk of exposure, and do what we can do as physicians on the individual level with the patient whose lives that we are touching on a daily basis, as well as on the national level, ensuring that our Senate, our Congress, our President are doing things that are going to protect and improve the living conditions of our most vulnerable populations. And I definitely want to thank ACMT for making this webinar possible and for caring so much about the populations that are disproportionately impacted by COVID. Thank you.
Well, thank you very much, Lisa, for a really outstanding presentation, along with Sheryl, and many thanks to Julian for running the Q&A session today. It was very informative, and this is clearly an incredibly important topic that is not going to go away, and we need to continue to think about solutions moving forward. So next slide, please. Just a reminder again, all the webinars were recorded and posted on the website. We'll send out an email on Friday once this webinar gets posted. And there's also a webinar Q&A component to the website as well. Next slide. Next week, we'll continue this COVID webinar series with two speakers. The main talk will be on epidemiological modeling of the impact of COVID-19 on hospital systems. This is going to be presented by Dr. Ali Klein from Johns Hopkins, and it should be really a very important talk, which will help the group understand more so the modeling issues and assumptions and how this very important modeling is currently being performed. And then we'll have a very important update from the front line from the Rio Grande Valley. As you may all know, the Rio Grande Valley is being especially hit right now in this phase of the pandemic. And Dr. Minerva Aranis from the University of Texas Rio Grande will be presenting an update from her city. So that will be next Wednesday, August 12th, 2020 at 3 p.m. Eastern Daylight Time. Next slide. Finally, the webinar series prospectus is available on our website. This will list upcoming webinars, including all the previous webinars as well, which are archived on the website, which are ready for on-demand viewing. Thank you very much and have a good day.